Hello everyone, welcome back to our channel. I'm Dr. Ashmita. Today I want to discuss about a clinical case scenario by reading out this question. Here, a 32-year-old corporate employee, developed swellings in the neck since 6 months, which are not responding to antibiotics. On examination, multiple, that is, 3 discrete cervical lymphadenopathy noted on the right side of the neck. Biopsy was done. Here is the histopathology image attached. So, by reading this question, what are the clues that we can derive to come to a diagnosis? So, it says a middle-aged person, 32 years is almost a middle-aged person with complaints of swelling in the neck, and it is history of 6 months. 6 months means it suggests of chronic picture. It is not due to an acute infection, but rather gives a chronic picture. And these are not responding. They are not responding to antibiotics. That means you can rule out any infective or reactive pathology. If it was infective, it could have responded to antibiotics. Since it is not responding to antibiotics, the infective etiology has been ruled out. And on that local examination, there are cervical lymph nodal enlargement, and that too multiple, like multiple almost 3 in continuous pattern could be on the right side of neck. So from this, there's a predilection of Hodgkin's lymphoma to attack the cervical lymph nodes, cervical and axillary and the inguinal. These are the most common lymph nodes affected by Hodgkin's lymphoma. So the given location of cervical lymph nodes, so it is like possibility. It more oftenly suggests of Hodgkin's picture, and also Hodgkin's lymphoma. It affects lymph nodes in a continuous spread. For example, this is one lymph node. It is affected. The adjacent lymph node to it, it gets affected. Likewise, all the adjacent lymph nodes get affected. If, for example, this one lymph node is affected, it attacks or it affects the immediately adjacent to it, like a chain reaction, one after the other. This lymph node affected, it will go to the next adjacent. Again, it will go to the immediate next adjacent. Again to the immediate next adjacent. It has a continuous pattern. This is called a contiguous spread. Contiguous spread seen in Hodgkin's kind of picture. And the histopathology here, you can find this classical cell, which is like a diagnostic hallmark of this disease. This cell is called a Reed Sternberg cell. Reed Sternberg cell, or also called RS cell. How does it look? It is a large cell. It has almost like eosinophilic, sometimes eosinophilic to basophilic in between tinge can be present of the cytoplasm. And there is a binucleation. There are two nuclei present. These are the two nuclei. They are mirror images of one another. And when you zoom in, that they have inside the nucleus, there's an inclusion which is eosinophilic, means pink color, pink inclusion on the eosinophilic inclusion. So binucleation, it shows binucleate cell with eosinophilic inclusion. It resembles an owl's eye. See, these are the owl's eye. Here you can see the inner black circle. You can denote it to the eosinophilic inclusion, and the surrounding this cornea, this yellowish orange. This you can say it is a nucleus. So there are binuclear. These two you represent the two nuclei, mirror images of one another, and inside the nucleus, this pupil, it denotes the eosinophilic inclusion. Hence, it appears like an owl's eye. This owl's eye appearance is very characteristic of a Reed-Sternberg cell. And in the background, there are mixed inflammatory cells. For example, there is a plasma cell here with eccentric nucleus. Cell with eccentric nucleus, plasma cell. Here is the eosinophil with orangeophilic cytoplasm. And there are abundant lymphocytes. All these are the lymphocytes. So it has a mixed background of lymphocytes plus plasma cells plus eosinophils. So with this presence of RS cells on this mixed inflammatory background, and these RSLs have typical owl-eye appearance. The diagnosis and this location of the cervical lymph node with multiple lymph node involvement, it gives you the diagnosis of Hodgkin's lymphoma. Of Hodgkin's lymphoma. So, here the most probable diagnosis is Hodgkin's lymphoma. Let us solve the questions. This first question says, describe the microscopic picture of the biopsy. So, the biopsy, the histopathology shows the characteristic Reed-Sternberg cell, which is a large binucleate cell with mirror image nuclei and prominent eosinophilic inclusions inside the nucleus, giving it a owl's eye appearance. And the background shows mixed inflammatory cells composed of lymphocytes, plasma cells, eosinophils. This is the description of the microscopic picture given. And the most probable diagnosis here is Hodgkin's lymphoma. To be very specific, given that RSL, classical RSL on this mixed inflammatory background, it is a mixed cellularity. It is a mixed cellularity variant classical classical Hodgkin's lymphoma. This is the diagnosis. And coming to the first, let us see the classification of this disease. So coming to the classification of Hodgkin's lymphoma, it is classified into number A, classical, and B, non-classical. Classical because it is associated with Epstein-Barr virus, whereas non-classical it is not associated with Epstein-Barr virus. And the classical ones, they are positive for CD markers like CD15 is positive, CD30 is positive, and PAX5 is positive. PAX5 is very specific for B cell development. Whereas the non-classical, they are positive for other different markers like CD20 is positive, CD45 is positive, and BCL6. These are positive. So under the classical, we have 4 variants. Under non-classical, we have only one. So the 4 variants are, just get familiarized with the terminology. The classical includes nodular sclerosis, mixed cellularity, lymphocyte rich, lymphocyte depleted. Whereas the non-classical includes only one, nodular lymphocyte predominant, Hodgkin's lymphoma, NLPHL. So these are the terms used in this classification. The nodular sclerosis is the most common worldwide. It is most common worldwide and it has the best prognosis. It has the best prognosis in the classical variant, in the classical Hodgkin's lymphoma, best prognosis, and it also shows certain mediastinal involvement. Mediastinal involvement. That means mediastinal masses can also be given in the history. It is specific for nodular sclerosis. Coming to the mixed cellularity, it is most common in India. It is most common in India. As the name suggests, it has a background of mixed inflammatory cells like lymphocytes, plasma cells, eosinophils. Mixed cellularity. Lymphocyte rich means there's abundant of lymphocytes in the background. Lymphocyte depleted, almost like dead lymphocytes or the mummified cells are present. And depleted means everything cells are degenerating or dying. Therefore, it has the worst prognosis among all. It has the worst prognosis. Coming to the nodular lymphocyte predominant Hodgkin's lymphoma, it has the best prognosis overall. Best prognosis overall is the nodular lymphocyte predominant Hodgkin's lymphoma. That is, the non-classical variant has best prognosis overall. If at all they are asking you the best prognosis in the classical, then it is nodular sclerosis. In both, all the nodular terms, this is nodular, this is the nodular, both have best prognosis. If they ask which is the best prognosis overall, it is the non-classical variant, nodular lymphocyte predominant Hodgkin's lymphoma. If they ask specifically which has the best prognosis among the classical variants, then it is the nodular sclerosis. Now, coming to this question, name the variants of the disease-defining cells. The disease-defining cell, that is the characteristic of this disease, are this Reed-Sternberg cell, RS cells. So they are asking the variants of this RS cells. What are the variants of RS cell? Now, what are the description I have said this about this owl's eye appearance? This is called a classical RS cell. So there are certain variants of this cell. We'll discuss now. The first image, it is of classical RS cell. It is classical RS cell. It shows you this binucleation with eosinophilic inclusion. This is a classical RS cell. It is seen in mixed cellularity. So it is like similar to this owl's eye. As I said, it is similar to an owl's eye appearance with the pupil denoting the eosinophilic inclusions, whereas the sclera, it represents the nucleus material. This is the nucleus, hence owl's eye appearance. This is a classical RS cell. It is seen in mixed cellularity. Mixed cellularity. Coming to the second image, here the RS cells are present. Here these are the RS cells are present, but around these cells there are certain gaps. There are certain clear halo zone around the cell. This halo zone, it is because of formalin fixation. Whenever a tissue is sent to the histopathology in a container, it is sent in formalin. It is sent in formalin. For example, this lymph node is sent in formalin. This formalin is acidic. It causes retraction. Cytoplasm shrinks. The cytoplasm of the cell, it will shrink, and therefore a gap is formed around the cell. This gap is called a lacuna. Lacuna means something gap or missing point or a defect is called a lacuna. Therefore, the gap around the cell is called lacuna. Therefore, it's named as lacunar RS cell. Lacunar RS cell. So around the cell, there's a clear gap around it. These are the lacunar RS cells. And the background obviously shows inflammatory background. This lacunar RS cells, these are found in nodular sclerosis of the classical Hodgkin's lymphoma. There's a rhyming, see, lacunar, nodular. Coming to the third image, here these RS cells, they show only one nucleus. Here there's only one nucleus and one eosinophilic inclusion. One nucleus, one eosinophilic nucleus inclusion. These are the mononuclear RS cell. Mononuclear RS cell, it is seen in lymphocyte-rich classical Hodgkin's lymphoma. So you can remember the rich people, the rich businessmen, rich industrialists, they impose monopoly over industrialization. Monopoly means like an ek niranjan. They impose all their own set of rules. They rule. So that's how you can remember. Mono means single. Mono means single. Mononuclear means a single nucleus. So monopoly is for rich people. So mononuclear RS cell is seen in lymphocyte-rich classical Hodgkin's lymphoma. The fourth image is it shows a RS cell, but here the cytoplasmic membranes, they are irregular membranes, and the nucleus is dark and condensed like a pycnotic. So it is typically, it shows you a pycnotic nucleus with irregular cytoplasmic membrane. So pycnotic, irregular cytoplasmic membrane. It represents a degenerating RS cell. So it gives this shriveled or dried up appearance. This is called a mummified RS cell. Mummy means dead body. Mummy is a dead body, Egypt dead body. So mummified means dead appearance. So it will be shrunken, pycnotic with a pycnotic nucleus, shrunken cytoplasm. Hence, mummified RS cell. Mummified RS cell seen in lymphocyte, lymphocyte depleted classical Hodgkin's lymphoma. Lymphocyte depleted. Whenever lymphocytes are depleting, that means they are dying, they're degenerating. It suggests of mummification, mummified RS cell. Okay. Coming to this fifth image, here the RS cell is very like typical. It shows this bubbly, bubbly or lobulated appearance. The nucleus is lobulated. The cell is lobulated. The membrane, it shows you lobules like a cloud. It's almost similar to a popcorn. It is similar to a popcorn. See, a popcorn has many lobules like this. Popcorn. So it gives you a popcorn appearance. This popcorn. So these are called popcorn cells or LNH cells. So popcorn cells or LNH cells. These popcorn cells are very characteristic of nodular lymphocyte predominant Hodgkin's lymphoma. That is the non-classical one. The non-classical Hodgkin's lymphoma show this popcorn cells. So it is seen in nodular lymphocyte predominant Hodgkin's lymphoma, that is non-classical Hodgkin's lymphoma, show you this popcorn cells. Let us revise these cells in the classification. So the nodular sclerosis shows you nodular, rhyming, lacunar RS cells are seen. Mixed cellularity shows classical. It shows classical RS cell. The background is mixed inflammatory cells like plasma cells, lymphocytes, and eosinophils. Lymphocyte rich, rich means monopoly, so mononuclear. Mononuclear RS cell. Mononuclear RS cell. Lymphocyte depleted. Depleted means dying, degenerating. So mummified. It shows you mummified. It shows you mummified RS cell. This nodular lymphocyte predominant Hodgkin's lymphoma, that is a non-classical one, shows you popcorn. Shows you popcorn RS cell. So this is all about Hodgkin's lymphoma that we have discussed in this chart. So we have discussed the microscopic picture of this biopsy. The probable diagnosis here is this mixed cellularity variant of classical Hodgkin's lymphoma. The variants of disease-defining cells. Disease-defining cells are the Reed-Sternberg cells. The variants of Reed-Sternberg cells we have just looked it into, and we have classified the disease. Classify the disease into classical, non-classical. Classical includes 4, non-classical includes 1. This is all about the questions discussed in this chart. Now, I want to discuss in brief about the pathogenesis of Hodgkin's lymphoma. Almost 60% of Hodgkin's lymphoma occur because of Epstein-Barr virus infection. This Epstein-Barr virus, it gains entry into the host via saliva of other infected person. That is through kissing. Hence, it is also called a kissing disease. From the saliva, they enter the oropharyngeal epithelium. The oropharyngeal epithelial cells are infected. From this, they enter the tonsils. Tonsils are nothing but a lymphoid tissue. It is a lymphoid tissue. Lymphoid tissue means, for example, if you consider this lymphoid tissue, take it a lymph node for example. It has cortex, outer cortex, inner medulla. This is the medulla. This is the cortex. Cortex contain follicles. These are the follicles. These follicles, lymphoid follicles, these are the lymphoid follicles. Each lymphoid follicle, it has an outer marginal zone. In between there's a mantle zone. Inside this is the germinal center. Which contain the B cells. So once this Epstein-Barr virus enters the tonsils, they infect the B cells. They infect B cells present in the germinal centers, and this infected B cells via lymphatics, that is the exit channel, of this lymph node. They enter the cervical lymph nodes. They enter the cervical lymph nodes, other regional lymph nodes, and carried via lymphatics to thoracic duct. It is carried to thoracic duct, which finally drain into left subclavian vein. Left subclavian vein. This is how it enters the circulation. This is how it gains access to a circulation. Via the circulation, again, the lymphatics, they are carried back to inguinal lymph node. The distant inguinal lymph nodes are also infected. So, while being in the circulation, the infected B cells present in the circulation, they invoke a host immune response by activating T lymphocytes, specifically CD8 cytotoxic T lymphocytes. They become reactive, they become aggressive to eliminate these infected B cells present in the circulation. Because of this aggressiveness or the reaction, the T lymphocytes, they adapt a different shapes. Like they have this irregular flowing skirt appearance. The cytoplasm is like a flowing skirt. It has this appearance, and they appear abutting over the adjacent RBCs. The flowing skirt abutting, they're falling over the adjacent RBCs. They're falling over the adjacent RBCs. This flowing skirt appearance of the T lymphocytes are present. This reactive T lymphocytes are called this reactive T lymphocytes. They are called Downey cells. They are called Downey cells. These Downey cells are not infected B cells. They are formed in response to infected B cells. They are formed in response to infected B cells. They themselves are not infected. They are formed in response to infected B cells. What are Downey cells? Downey cells are the reactive T lymphocytes. They are formed in response to the infected B cells. Another thing, the infected B cells, for example, this is a B cell. It has a nucleus, host DNA. This virus enters it, it integrates its genome into the host genome, and they express. And how do they gain entry into B cell? This B cell has a receptor called CD21. CD21 allows entry of Epstein-Barr virus. And once it integrates its genome with the host genome, they express viral oncoproteins onto the surface. This viral oncoprotein is called LMP1. LMP1, that is latent membrane protein 1, latent membrane protein 1, LMP1. It mimics CD40 receptor. It mimics CD40, which is also a natural receptor present on B cells. So this CD40, it is normally present on B cell whenever CD40 ligand, it binds to CD40 receptor, then it activates a transcription factor present in cytoplasm called NF-kappa B. Only when ligand binds, it activates transcription factor NF-kappa B that translocates to the nucleus and cause gene expression and cause B cell proliferation. B cell proliferation. What happens in this Epstein-Barr virus infected B cells are that they express this LMP1, latent membrane protein 1, which is an oncoprotein, and they mimic CD40 receptor, and they are constantly active without ligand. Without the need of ligand, they are constantly active. If they are constantly active, they'll send signals to this NF-kappa B, which translocate to nucleus, and they cause expression of genes, cause B cell proliferation. Therefore, there is continuous B cell proliferation. LMP1, this LMP1 will stimulate NF-kappa B pathway transcription factor, which translocate to nucleus, cause expression of genes, that cause proliferation of B cells, proliferation of B cells. It is a continuous process. Even without ligand, they are continuously active. So there is that is continuous activity of this pathway. This is how B cells proliferate. Also, Whenever Epstein-Barr virus infects a B cell, there is overexpression of BCL2. BCL2. BCL2 is overexpressed, which is anti-apoptotic, So apoptosis of infected B cells is not done. The infected B cells survive. The infected B cells survive. This is how they proliferate and survive. This is how they proliferate and survive with the help of this LMP1. In other cases of not Hodgkin's lymphoma, which are not associated with Epstein-Barr virus, the mechanism is again the same. NF-kappa B has to be activated. This is controlled by a gene present on chromosome 2. Chromosome 2 contains a gene called REL gene. So because of this mutation of chromosome 2, the REL gene is amplified. It is amplified. When this is amplified, the NF-kappa B pathway is stimulated. It is continuously stimulated. It causes B cell proliferation. It causes B cell proliferation. This is one thing. Also, there can be a mutation of JAK-STAT pathway. Mutation of JAK-STAT pathways that continuously cause B cell proliferation. Other is the inhibitors of NF-kappa B called I-kappa B. They are lost. Hence the NF-kappa B pathways are stimulated, very extensively stimulated. And certain A20 proteins, this is a protein, A20 proteins, which cause the apoptosis, which cause apoptosis of B cells. These are also lost. When apoptosis is not occurring, the B cells survive. So all these factors culminate constitutively, they form B cell proliferation. They cause B cell proliferation and survival. B cell proliferation and survival that will lead to Hodgkin's lymphoma. This is a brief pathogenesis about Hodgkin's lymphoma, and the clinical features here being, since it infects the cervical lymph nodes and everything, so the clinical features here are cervical lymphadenopathy. Cervical lymphadenopathy is one thing. Hepatosplenomegaly can be present whenever this infected B cells they reach liver and spleen, and there's fever. Though it is like a non-specific finding, it is because of interleukin 1 and TNF alpha. These are the few symptoms. Also, there can be presence of B symptoms. B symptoms means fever. It is a triad of fever, weight loss, unintentional weight loss, and night sweats. These are the clinical features of Hodgkin's lymphoma. Now, let us differentiate Hodgkin's lymphoma and non-Hodgkin's lymphoma. Few differences that could be helpful for viva. The most common age group for Hodgkin's shows a bimodal age group distribution. It is more present in the young adults, almost teenagers, and elderly. So it has this extreme two modes of variation, two modes of spread among the age group. Non-Hodgkin's, they occur in elderly above 55 years. Most common site for Hodgkin's is cervical lymph node, axillary lymph node, and inguinal lymph node. For non-Hodgkin's, these are deep-seated like Waldeyer's ring and mesenteric lymph nodes are involved. They are more deep-seated. Extranodal involvement is little rare in Hodgkin's lymphoma, whereas it is more common. It is more common in non-Hodgkin's lymphoma. And the spread is here, it is called contiguous spread. Contiguous means continuous. For example, this lymph node is affected. It will immediately affect the adjacent lymph node, thereby other lymph node just adjacent to it. It's like a chain reaction. Like a chain reaction, continuous spread occurs. In non-Hodgkin's, there is skip pattern. This lymph node affected, it will skip this will skip this, the other lymph node will be affected. It will skip again, other lymph node is affected. Like this, it has a skip pattern. This is called non-contiguous. It has a non-contiguous spread. This is a brief difference between Hodgkin's versus non-Hodgkin's that is useful for viva as well. In detail, since Hodgkin's lymphoma is very important topic for both undergraduates and postgraduates, I will discuss this Hodgkin's lymphoma in detail in part 2 video. Thank you everyone.